Hello, my name is Hannah Davis, and I'm from the Patient-Led Research Collaborative. I'm also a long COVID patient. My experience started on March 25th, 2020. I've been sick for 477 days. My first symptom was actually that I couldn't read a text message. I was unable to parse what the meaning actually was saying. An hour later, I took my temperature and realized I had a fever. Over the next few months, I experienced severe brain fog, memory loss. I forgot my partner's name. I forgot to look both ways when crossing the street. I forgot how to cook. I would regularly just forget that I was cooking something and regularly started fires in my kitchen. I was completely unable to drive. I had severe dysexecutive functioning, a low-grade fever for over 6 months, loss of taste, loss of feeling in my arms and hands, tachycardia on minimal activity. When I stood up, I would reach 150 to 160 beats per minute. I had pain in all muscles and joints, heart palpitations, severe headaches, blurry vision, difficulty making meaning from text, talking and finding words, sensitivity to light and noise, a complete loss of attention span, insomnia, tinnitus, general slowness, difficulty temperature regulating, phantom smells, internal tremors, patache, a severe headache just from thinking. And these are just a subset of my symptoms. At the beginning of the pandemic, neurological symptoms were not considered part of COVID. At one point, I went to the ER and was sent home with an inhaler. Before I got sick, I worked in machine learning and I haven't been able to return to work. I am an unusual patient in that I had done neuropsychological results before I got sick to see if I had ADHD. A few months after, I did the same testing with the same provider. My processing speed had dropped from the 96th percentile pre-COVID to the 14th percentile post-COVID. By everyone's guidelines and definition, I am considered a mild case. I work with Dr. Akrami on the patient-led research team. One of the areas that we studied was cognitive dysfunction and memory loss and how these impact patients' daily life. We found that most people experienced at least one of these symptoms. Of people who experience cognitive dysfunction and memory loss, 86% have their work affected, 85% have difficulty making serious decisions, 75% have difficulty communicating thoughts and needs, 68% had difficulty communicating and having conversations with others. This also affected areas of life, including maintaining medication schedules, following simple instructions, and being unable to drive. To me, one of the biggest things we found was that there was no difference in memory symptoms by age, no difference in cognitive dysfunction by age, and no difference in the impact of these symptoms on life by age. These are as common in 18 to 29-year-olds as in people over 60. I think that brain fog is a really vague term to communicate the severity of what patients experience with this symptom. I want to take a moment to read a couple of patient quotes. Mother has started to help me take the medications I'm on because I can't remember if I've taken them immediately after having the bottle in my hand. I was trying to fill out a mortgage application form and couldn't remember our rent. I put $37.50 a month. My partner said no, it's $13.75. So I put $13,750. My partner said no, so I tried several more times. I was just guessing numbers. Sitting on the toilet to pee and had to stop for a second to think if I was really there and not about to pee myself or the bed. I forgot how to do normal routines like running a meeting at work. I felt lost driving and had to stop and find my position in a GPS to be able to drive back home. It's a route I have done hundreds of times. I can't hold multiple trains of thought. If I tell myself I have to water my plants, I must do it before another thought comes into my mind, because otherwise I will forget. I had to terminate many phone calls because I could no longer comprehend the speakers nor communicate clearly with them. These types of experiences are happening in patients of all ages. I wanted to talk about a few research directions and biases in long COVID research. The first is that it's vital to include PCR and antibody negative patients in research. We accepted both symptomatic positive and symptomatic negative patients and compared the two. The primary difference in the cohorts was not in the symptoms, but in the time they were able to get tested. As we all know, the PCR tests have high false negative rates. They start at 20%. Every day after the third day of symptoms, that false negative rate increases. And we found that the positive cohort got tested at a median of 6 days, and the negative cohort got tested at a median of 43 days. The only statistically significant difference of 205 symptoms was loss of taste and smell. Because this was a primarily first wave cohort and there was testing inaccessibility, this is likely because if you had those obvious COVID symptoms, you were able to get a test and therefore be more likely to test early enough. This finding of no symptomatic differences between symptomatic negative and symptomatic positive cohorts has been validated by 6 other global studies. Additionally, there's research that has come out, especially in the last few months, that show that low antibody responses might actually be a feature of long COVID. The first study here shows that no or low baseline IgG levels were actually able to predict persistent symptoms at 7 months in a non-hospitalized cohort. The second showed the same in a hospitalized cohort. The third showed that there were additional negatively correlated immune responses, both T cells and select B cells, with long COVID. The fourth showed that viral persistence in the gut was associated with lower levels of and slower generation of IgA and IgG antibodies. And the last one curiously shows that of all patients who seroreverted, meaning that they lost their antibodies, only 2% of PCR patients seroreverted compared to 27% of PCR negative. Additionally, antibody tests vary wildly between male and female patients. Males are 4 times more likely to retain antibodies. In one study, 36% of female patients lost antibodies between month 3 and 6 compared to 8% of males. Overall, 80% of those who lose antibodies are female. Another study showed that antibody tests are more accurate on men between age 40 and 59, but least accurate on women, people under 40, and people over 70. An additional study showed that antibody tests were validated against predominantly hospitalized patients and missed 10 to 30% of non-hospitalized cases. If we require antibody testing for long COVID research, we will accidentally create a data set that is biased toward male patients and female patients with a stronger immune response, which is just not the typical long COVID patient. We also may potentially miss the clue of patients not seroconverting or seroreverting earlier, which actually might be a clue to the pathophysiology of long COVID. In 2 recent studies, those without lab confirmation of COVID experienced an 8-week delay in care, were less likely to have adequate time off, less likely to have adequate rest, more likely to experience lost income, more likely to be unable to live alone at 6 weeks, and more likely to have pain, anxiety, and mood symptoms, likely from disbelief and lack of care. Non-hospitalized patients are 75% more likely to not have had lab confirmation of COVID. Secondly, we need to build on existing post-viral research. This is one of the World Health Organization's overall objectives for the long COVID global research roadmap. Post-viral research is a understudied area, but in the last few years, there have been findings in all of these areas that we need to build on. One is in neuroimaging. Dr. Jared Younger and Dr. Michael Van Elziker have both identified neuroimaging techniques for post-viral patients, looking at brain temperature and neurovascular dysfunction. It's important to identify neuroimaging techniques, especially where MRIs are coming back clean in most long COVID patients. Other areas that need to be built upon and studied include metabolic profiling, cerebral blood flow, overlaps with connective tissue disorders, altered T and B cells, elevated blood lactate, reactivations of additional viruses, mitochondrial fragmentation, and many others. A few initial research questions for long COVID. Are those with long COVID more likely to seroconvert earlier or never seroconvert? Is there viral persistence in places like the gut, tissue, or elsewhere? How is the immune response in non-hospitalized long COVID patients different than those in mild cases and those who are hospitalized? What causes the hypometabolism that has been found in the brains of long COVID patients? What causes post-exertional malaise and relapses? What is the overlap between connective tissue, collagen breakdown, the cervical spine, and long COVID? And again, what imaging or diagnostic tools can identify these persisting neurological symptoms, particularly in patients with normal MRIs and X-rays? To conclude, we need a comprehensive selection of patients in long COVID research. Most long COVID patients were not hospitalized. Many didn't experience severe respiratory symptoms. Many were not PCR or antibody positive, and a clinical diagnosed subset must be included. Many had quote-unquote mild acute cases. Many never had low oxygen levels. We need to include the right symptoms. We still see a lot of research proposals that miss neurological, cognitive, and post-exertional malaise questions. Often they miss questions on relapses, which are a core component of this experience. And all of this is particularly true when using machine learning. If we don't, algorithms will be biased without a representative patient and symptom data set. Thank you so much.